Welcome, everybody. I just want to thank you all for tuning in. The title of this presentation is Examining Prevalence of Non-Medical Prescription Opioid Use by Race and Ethnicity from 2015 to 2018 among a national sample. My name is Connor Imbody. I also worked on this project with Dr. Melvin Livingston and Dr. Natalie Crawford. Just an overview of everything we're going to look at today. We're going to start with some background and rationale, and then we'll move into the methods and results from this study. As many people may know, drug overdose is actually the leading cause of death of Americans under the age of 50. In 2017, there were a little over 70,000 drug overdose deaths in the country. About 2/3 of those 70,000 deaths were attributable to all kinds of opioids. So that's 47,600, as you can see on the chart. And it's been rising significantly in recent years. Furthermore, of that 70,000 drug overdose deaths, a full quarter of those, about 16,500, involved prescription opioids specifically. So that accounts for about 46 prescription opioid deaths per day. And then furthermore, 1.7 million Americans had a prescription opioid substance use disorder in 2017. As you can see here on the chart, the blue line for prescription opioids show how prescription opioids for much of the last 2 decades have accounted for the largest proportion of the national drug overdose deaths. However, in more recent years, we've seen a spike in fentanyl and heroin accounting for more deaths. Opioid-involved overdose deaths increased 90% from 2013 to 2017, and that's largely driven by that yellow line there with fentanyl mainly contributing to that. In general, with the literature, we know some trends based on opioid-involved overdose deaths. We know that generally the epidemic disproportionately impacts men. In 2017, 2/3 of opioid-involved overdose deaths were among men. We know that the epidemic disproportionately impacts younger populations. So in 2016, a full 20% of all deaths among 24 to 35-year-olds and 12.4% among 15 to 24-year-olds were attributable to opioids. It's a very high number. However, we're not seeing some of those results holding with more recent data, especially when we look at different race and ethnic groups. From 2015 to 2017, among Blacks, we found that opioid-involved overdose death rates have been increasing among older populations. So older Blacks among the ages of 45 to 54 saw their opioid-involved overdose death rates increase from a rate of 19.3 to 41.9, so more than doubling. And a similar pattern was seen in the rates among those ages 55 to 64. From a rate of 21.8 to 42.7. Furthermore, when we look at our large central metropolitan areas, the big cities in our country, we're seeing that among people ages 45 to 54, synthetic opioids were involved in 70% of all opioid overdose deaths among Blacks, compared to just 56% among Hispanics and 54.2% among whites. For over a decade, we've known that white rural Americans have disproportionately experienced opioid overdose deaths. However, again, in more recent years, Black and Latino Americans in urban and suburban areas are experiencing alarming increases in opioid overdose death compared to white populations. Specifically in 2017, the rate of prescription opioid overdose deaths was 6.9 among non-Hispanic whites, and 3.5 among non-Hispanic Black populations, while just about 9 years earlier in 2008, we saw that the rates were 6.3 and 1.9 for non-Hispanic whites and non-Hispanic Black populations, respectively. So we're seeing significant increases in non-Hispanic Black populations with smaller increases in non-Hispanic white populations. So that disparity is closing. And from 2015 to 2017, non-Hispanic Black adults experienced the greatest growth in opioid overdose compared to any other racial category, whether we looked at rural, metropolitan, or urban areas. So all of these findings are really important. And due to all of these racial demographic shifts that we're seeing in opioid deaths in recent years, we wanted to look at and investigate more if those same shifts were occurring in terms of opioid use. Specifically, we wanted to look at prescription opioids because, as we've seen and been talking about, historically they've been the leading cause of drug overdose deaths until just in the last 5 years or so. And they remain today to be one of the most used opioids. And particularly, our study examines non-medical prescription opioid use, which we're going to define in a few minutes. So our research question was, is NMPO use among Black people comparable to white NMPO use, despite Black people representing a smaller proportion of the general population? In terms of our data, we looked at 2015 to 2018 National Survey on Drug Use and Health data. This is the most current data for this survey. This survey, every year, they interview about 70,000 individuals. And importantly, this survey excludes some specific special populations, which include people actively serving in the armed forces, those incarcerated, and those institutionalized. For our purposes, we focus specifically on those that were adults, so 18 years and up, and those who responded to some specific pain reliever misuse questions that we'll look at in a few minutes. Overall, with these restrictions, that led to a sample of 154,350 individuals. Non-medical prescription opioid use is defined by these three criteria. The first is just kind of the general broad question of, have you ever even once used any prescription pain reliever in a way a doctor did not direct you to use it? The second criteria is just a slight adjustment of that general question, adding the context of within the past 30 days, and then also using the names of specific pain relievers, such as Oxycontin, to help jog a respondent's memory. And then finally, there were questions that were very similar to criteria number 2 that were looking within the past 12 months. And they were, again, asking for very specific pain relievers, such as like, in the past 12 months, have you misused Oxycontin in a way that a doctor did not direct you to use it? So in terms of our variables, the main independent variable was race and ethnicity. We were looking at 3 different groups: whites, Blacks, and Hispanics. These were our control variables that we looked at for our analysis. We looked at sex, age, residential geography. We just looked at urban versus rural. We looked at educational attainment, employment status, and health insurance. In terms of our analysis, we started out with a very simple descriptive analysis, which just means we wanted to get the numbers of people in each group. For example, how many Black participants do we have in the sample? And then we got their weighted percentages. So how much do those populations represent in that category? From there, we did a bivariate analysis, which is very similar to the descriptive analysis, but we were stratifying by race and ethnicity. And then finally, we did 3 logistic regression models. The first was an unadjusted model that just looked at NMPO use and its relationship to race. Secondly, we did an adjusted model where we controlled for geographic residence, education, employment, and health insurance. And then finally, we did another adjusted model that controlled for those same variables, but then we added in age and sex. And all of this analysis was performed in SAS, statistical software, to account for the complex survey design of the National Survey on Drug Use and Health. So in terms of our results, let's first start with the descriptive results that we found. We found that overall NMPO use prevalence was 4.31%, as you can see in this top red box. We found that NMPO use by race was 4.46% among whites, 3.75% among Blacks, and 4.13% among Hispanics. This sample was about 70% white, 13% Black, and 17% Hispanic. Sample had slightly more females in it. It was about 52% female. It was 85% urban and about 15% rural. Importantly to note, the Hispanic participants were found to represent fewer rural participants and fewer older respondents. And then additionally, we found that there was lower educational attainment among Blacks and Hispanics compared to whites. In terms of our bivariate analysis, where we stratified by race, our first significant finding was that there were significant differences in NMPO use by race ethnicity. Interestingly, NMPO use among Hispanics was comparable to that of whites. You can see that in the top red box where the Hispanic NMPO use percentage was 4.13%, and whites was 4.46%. In terms of rurality, we found that there were no significant differences between rural and urban respondents. Additionally, we found that rural Hispanics had very high NMPO use. Their NMPO use was 4.43%, compared to just 4.04% among rural whites and 3.31% among rural Blacks. Next, in terms of education, we found that there were different NMPO use patterns by educational attainment for whites and Hispanics. So generally, the trend that we see in the literature is that as education increases, NMPO use or prescription opioid use decreases. And you can see that in the middle column there where Blacks, for educational attainment, as education goes up, NMPO use is decreasing. However, for both whites and Hispanics, we saw that for individuals that had some college or an associate's degree, we saw a slight uptick in NMPO use that differed from the general trend that we see in the literature. And then finally, in terms of employment status, we found that unemployed whites had significantly higher NMPO use than their Black and Hispanic counterparts. We can see that unemployed whites had an NMPO use of 10.54%, and that's more than double the NMPO use of Black unemployed individuals at 5.91%, and still significantly higher than unemployed Hispanics, where the NMPO use was 7.58%. In terms of our regression model results, what you're seeing are the unadjusted model and the two adjusted models that we ran. Across all three models, we could clearly see that NMPO use is decreasing among all race ethnic groups. As you can see, all the lines are going down. And then the other important finding with this was that that rate of decreasing among the different race ethnic groups across all the models was not significantly different. So the rates were equitable. That's a good thing because we're not seeing any one race ethnic group, for example, increasing while the other two decreased. And there's no significant disparities in the rate of that decreasing for NMPO use. So they all are decreasing and all decreasing at an equitable rate. So again, some of our main conclusions were that we did find NMPO use was significantly different across the three race ethnic groups that we looked at. However, Hispanic populations had comparable rates to white populations, which was a surprising finding. Furthermore, we found that NMPO use was very high among unemployed whites compared to their Black and Hispanic counterparts. NMPO use was higher than expected among white and Hispanic populations when we were looking at that some college education or an associate's degree level, and that did not follow the trend of the literature. And then finally, the big take-home message I want to leave you with is that we did find NMPO use is decreasing at an equitable rate across Black, Hispanic, and white populations. So some important limitations that we need to talk about in the context of this study is, first and foremost, the issue of non-response bias. The National Survey on Drug Use and Health is obviously asking about very sensitive topics related to drug use. And that can lead people to not want to answer or not want to answer completely honestly. And to address that non-response bias, the National Survey on Drug Use and Health uses something called the ACASI, which is audio computer assisted self-interviewing. Basically what that means is for some of the more sensitive questions, rather than a human interviewer, they will have the participant work directly with a computer prompt to input their answers for those sensitive questions, and Akasi has been shown to reduce the non-response bias in studies. Furthermore, we need to talk about those special populations again. The excluded special populations that are not accounted for in this sample, while they only represent about 3% of the US population, we do know from other studies that they can have significantly different opioid use patterns. Specifically, a recent study found that past year NMPO use among Black incarcerated men in Kentucky was 20.5%, which is over 4 times greater than NMPO use among the general Black population. So that's a significantly higher group that those special populations are not really accounted for in our study, and they need their own special consideration. Finally, our data did not allow us to examine heroin and fentanyl use. We know that those are increasing in recent years and would have liked to look at that. We just simply didn't have the numbers to be able to run analysis for those. Perhaps with a few more years of data from the National Survey on Drug Use and Health, we'll be able to run it. Or we could look at another data source for potentially getting some answers about looking at those two opioids. In terms of strengths, this is the most current examination of NMPO use by race ethnicity, which is important based on the trends in opioid overdose deaths that we've been seeing by race ethnicity in recent years, and how those are increasing significantly for Black and Hispanic populations. Importantly, this study also is examining Hispanic NMPO use. Unfortunately, Hispanic populations are largely excluded from much of the literature on opioid use in general, but also prescription opioids in particular. This study is a large nationally representative sample, but it also has very specific subpopulation focus that we can use to develop different preventative strategies for different groups. And then finally, in terms of future studies and public health impact, I think the next biggest question to consider is there a connection between decreasing NMPO use and increasing heroin and fentanyl opioid use? So we know heroin and fentanyl opioid use are increasing in recent years very significantly. And we know that there have been different public health measures to rein in NMPO misuse, such as the greater restriction on prescribing practices around prescription opioids. And so my concern is that we'll see somewhat of a seesaw effect, that we're not really dealing with the underlying issues of addiction with those who developed an opioid addiction related to prescription opioids. And as it becomes harder and harder to get those prescription opioids, we may see less non-medical prescription opioid misuse, as we found in our study. But that could be a sign that people are being pushed to more available drugs, such as heroin and fentanyl, that are also more potent and more deadly, which overall is going to be a net negative, that we're going to just be pushing people to more deadly opioids and see even greater overall drug overdose deaths. So we need more literature to kind of contextualize our findings to see if that seesaw effect is happening, or to better understand what the relationship is between prescription opioids and heroin and fentanyl. Furthermore, as I said before, we really need more literature regarding all forms of opioid use, but specifically prescription opioid use among Hispanic populations. As our study found, we found that rural Hispanic populations had very high NMPO use, and that's something we need to have for very contextualized interventions. We need to look at the importance of intersectionality. So what does it mean to be a woman that is living in a rural area that is also Hispanic in terms of her risk for NMPO use? And what are her unique barriers to treatment and to education and all these different public health interventions? So we need more of that data, and we need to have more Hispanic inclusion in literature related to opioid research. And then additionally, the same could be said for Black populations as well, particularly because of the trends that we're seeing in rising opioid overdose deaths among Black and Hispanic populations. We need to know up-to-date information and data to be able to make culturally appropriate interventions and to be able to tailor our interventions so that we can make a strong impact on these different populations. It can't be a one-size-fits-all. It needs to be very specific and textualized. So with all of that, I just want to thank you all for tuning in for this presentation. I look forward to talking with all of you in the Q&A. So thank you.